talk about a very important topic now, that is shock. And every year in the entrance exam, you have at least 2 questions from this topic. Also in your college exam, this is usually a long question or a short note which you get. So I really want you to understand the concept behind shock and the newer modalities and the new developments in this field, because that is a constant question in the entrance exams. Now, the first thing which I want you to know is what is the definition of shock. Now, this you must have covered in physiology as well. And a very simple definition of shock is that it is hypoxia at the cellular level, right? It is hypoxia at the cellular level, and there can be various causes of shock. The first one which we're going to talk about is the most common, that is hypovolemic shock. So hypovolemic or hemorrhagic shock is the most common type of shock. In fact, Bailey says that if a patient presents with shock and you are unsure about the etiology, it is safe to treat it as, it is safe to assume that it is hypovolemic shock. So initially you can assume that the patient has hypovolemic shock and start treating the patient, and then you can work up the etiology if you're unsure what exactly is the patient suffering from. Now, hypovolemic or hemorrhagic shock. If you talk about hemorrhagic shock, it can be of 2 types. You can either have concealed bleeding. You can either have concealed bleeding which we cannot see, or there can be revealed bleeding, which exactly we can measure the blood loss and we can see the blood loss happening. Okay. Now, I'll just show you an image to depict the 2. This is an image similar to a case which I saw when I was a first year postgraduate. So there was a chef who was working, and by some mistake, we don't know exactly what happened, but the chef's knife just went through his thigh. And when he came to the hospital, he had this huge gash on the thigh which was bleeding, and he was actively oozing out blood from there, and there were many spurters there. Okay. So you could actually see blood loss happening, and that is revealed blood. You know that blood loss is happening and the patient is in shock. Okay. The other one is concealed hemorrhage. Concealed hemorrhage is when you can't see that blood loss is happening, but it is accumulating somewhere. So what are the sites where blood can accumulate without us coming to know about it or actually seeing the blood loss? So you can have blood accumulation in the neck, in the thorax, as you can see in this image, in the abdomen, and in the pelvis, and long bones like femur. So these are the concealed areas where blood loss can happen and the patient can go in shock without actually a single drop of blood being seen outside. Okay. One thing which I want you to remember here, this is very important for the exam. Isolated head injury and isolated head bleed can never give rise to hypovolemic shock. This is a very important statement which I want you to remember. There is not enough space in the cranial cavity. Even if there is blood loss, the patient will not develop hypovolemic shock, right? So isolated head injury and isolated head bleed will never give rise to hypovolemic shock. If there is a patient, if patient has head injury and hypovolemic shock, then search for other sites of bleeding. Then we need to search for other sites of bleeding. right? And I've told you other sites are going to be, you can either look at the floor if there's blood loss, or those concealed areas which I've just told you, right? So this is the first thing which I want you to remember. So another thing which I want you to remember, that bleeding can either happen, it can either be an arterial source of bleeding, or it can be a venous source of bleeding. Okay. Now, arterial, you can have two types of injuries. Either there can be transection of the artery, or there can just be a laceration of the artery. Now, a question which is asked in the exam, transection versus laceration, which one is going to bleed more? Transected means it is completely cut into two pieces. Transected. Lacerated means there's just a cut over the artery. Now, lacerations of the artery bleed more. They bleed more as compared to transection. Why? Because when it is transected, you must have studied in pathology that whenever there is a vessel injury, the first response is vasospasm. There is spasm of the artery, right? So in transection, the vasospasm will reduce the bleeding. Whereas when there is a laceration, because of the spasm, the opening increases. The opening increases and there is more bleeding. So this is point number one which I want you to remember, that a lacerated artery bleeds more than a transected artery. Now second, venous blood, it is a gradual ooze. It is a gradual ooze. So because it is gradual ooze, more time for body to compensate. We'll talk about the compensation when I discuss the parameters of hypovolemic shock, but more time for body to compensate. And because the body can compensate more, these patients with venous bleeding will present late. I hope you understand this point. Because there is a gradual ooze, the body's mechanisms, the physiology can recalibrate and can adjust to that blood loss. So patients with a venous ooze will present very late when the BP suddenly drops. Okay, so this is another point which I want you to remember. Now, when we talk about hemorrhage, supposing I'm doing surgery and during surgery there can be hemorrhage, or even after surgery there can be hemorrhage. So what are the various types of hemorrhages which you should know about? This is again a frequent MCQ asked in the exam. So you can have primary hemorrhage. Primary hemorrhage is the hemorrhage during surgery. When during surgery you have a bleed, that is primary hemorrhage. The second one is reactionary hemorrhage. This is the one which has been asked most commonly, reactionary hemorrhage. Reactionary hemorrhage can occur 4 to 24 hours after surgery. Can occur 4 to 24 hours after surgery. Okay. So what are the causes of reactionary hemorrhage? The causes of reactionary hemorrhage would be increase in blood pressure, or slippage of the knot. Slippage of knot. In previous modules, we've spoken about surgical knots. Which knot would the surgeon have used which can slip easily? Yes, if you use a granny's knot, then it can slip and it can give rise to a reactionary hemorrhage later on. Also, what happens is that supposing when I am doing a surgery, the anesthetist maintains the BP at a lower range than normal, so that I have a bloodless field when I'm doing surgery. Okay. But if I close at the same low BP and then the BP rises in the post-operative period, then small oozers and vessels can start bleeding later on. And I won't come to know about it unless it manifests in the drain. Okay. Which is why, as a surgeon, before I start closing any wound, I ask the anesthetist, is the blood pressure close to the baseline blood pressure? So I will only start closing when the blood pressure is close to the baseline blood pressure, so that I don't miss out on this reactionary hemorrhage later on. Okay. The final type of hemorrhage is secondary hemorrhage. Now, secondary hemorrhage will occur after a few days. And this usually occurs because of sloughing of the artery. sloughing of the artery or the vessel, and this can be secondary to infection. It is usually secondary to infection. So these are the three types of hemorrhages which you should know about. Okay. So what we've discussed till now, we've discussed that hypovolemic shock is the most common type of shock, and we've discussed what are the various causes which can give rise to it. So this is a very important table which we're going to discuss about hypovolemic shock, and every year this is asked in the exam. So what we are going to discuss here, there are 4 classes of hypovolemic shock. So you have class 1, class 2, class 3 and class 4. And the various parameters which we need to discuss in hypovolemic shock are percentage of blood volume lost. This is the most important parameter, percentage of blood volume loss, asked a lot of time. Amount of blood loss. Amount of blood loss. The other parameters which we need to discuss are pulse rate, systolic blood pressure, diastolic blood pressure, pulse pressure. Pulse pressure, you know, is systolic blood pressure minus diastolic blood pressure. You have respiratory rate, urine output, mental status. You have base deficit. Base deficit, I'll tell you what exactly is base deficit. And you have management. So these are the various parameters which we need to discuss in all 4 classes of hypovolemic shock. Now I know it looks like a lot of parameters, but I'm really going to simplify this table for you, right? And it'll be very easy for you to understand it. So the first thing which we need to discuss is what is the percentage of blood volume loss in each class of hypovolemic shock. And before I tell you this, I want to show you a video which will clarify a lot of things for you. Okay. This is a video which I always show in my class, and this is a video of 2 great tennis players, Federer and Djokovic. This is the US Open finals, right? Federer is the one in red and Djokovic is the one in yellow. And you can see Djokovic has served, and I just want you to see what Federer does in this point. So it looks here as if he's going to lose the point, but he just pulls out an amazing shot. And I want you to watch the slow motion to really understand what exactly did Federer do. And this gave a match point, and he ultimately won the championship. So you can see here that it looks as if he's losing the point. He just casually runs back and hits the ball between his legs for a winner, right? So between his legs for a winner. Right, so there are a couple of things which I want you to learn from this video. So in the post-match interview, Federer was asked that was it a fluke shot or did you practice this shot quite a lot of times? So Federer said in the post-match interview that it wasn't a fluke. I've practiced this shot more than 1,000 times, right? And he said that the first 200, 300 times I used to get it wrong. But after that, the frequency at which I was getting it right increased tremendously. Okay. So one thing which I want all of you to remember is that practice is what is going to make you perfect. If you don't solve MCQs, if you don't practice your MCQs, it will be difficult for you to crack your entrance exams. So keep on practicing MCQs. Yes, initially you will make mistakes, but as you practice them more, you'll get better at them. Okay. Now the second thing which I want to tell you is that the scoring of a tennis game, most of you must be knowing, is 0-0, that is love all, and then you have 15, 30, 40 and game over. And that is what I want you to remember to memorize the classes of hypovolemic shock. So the classes of hypovolemic shock, very easy to remember. Just remember the scoring of a tennis game, right? So you have 0 to 15%, that is class 1, 15 to 30% is class 2, 30 to 40% is class 3, and game over for the patient, that is more than 40%, is class 4. So very easy to remember. Now again, the amount of blood loss, this is approximately 400 to 500 cc, and you just keep on adding 500 to each class. So this is going to be 1 liter, this is going to be close to 1.5 liters, and this is more than 2 liters. Right? So just keep on adding 500, 500 in each class. Now, let's talk about class 1 hypovolemic shock or class 1 hypovolemia. Okay? Now, you have a patient who's lost around 400 to 500 cc of blood. I'm sure a lot of you watching this video must have donated blood as well. And if you donate blood, like I donate blood every 2 to 3 months, my hemoglobin is on the higher side. I have a hemoglobin of close to 17. So the doctors have told me every 3 months I have to donate blood. Okay. So if you donate blood, they take approximately 450 to 500 cc of your blood. Right. Now, if you've given that much blood, you've experienced class 1 hypovolemia. Now tell me, all of you, those who've donated blood, what happens to your parameters once you've donated blood? Well, I don't know about you, but for me, nothing changes. Everything remains normal, right? Nothing changes. Even my mental status remains normal. The base deficit, you need to understand base deficit. That means a deficit in base means an excess in acid, right? And when there is shock, there is bound to be acidosis. Okay? But class 1, nothing is changing. So base deficit is also normal. It is 0 to minus 2. It is 0 to minus 2 milliequivalents per liter. Okay? And once you've donated blood, what do they give you after blood donation? Well, I fondly remember that you get a fruity and a packet of biscuits. Right, so that's what you get after blood donation. So the management of class 1 hypovolemia is oral liquids. That's all you require. Okay. Let's talk about class 2 shock now. Now, class 2 shock is known as the compensated phase of hypovolemic shock. This is very important. This is the compensated phase of hypovolemic shock. Why are we saying it's the compensated phase? Let's look at the physiology of class 2 shock. So if you look at the physiology of class 2 shock, when there is blood loss, you know that the sympathetic system is stimulated, right? You must have read this in physiology, that the sympathetic system is stimulated. And when the sympathetic system is stimulated, adrenaline and NORAD are released. Adrenaline and noradrenaline are released from the system. Now, what is the first change which adrenaline and noradrenaline will bring about? You've read this in pharmacology, that the first change which adrenaline and noradrenaline will bring about is tachycardia or increase in pulse rate. And this is the earliest indicator of hypovolemia. This question has also been asked many times. This is the earliest indicator of hypovolemia, tachycardia. What else is ADR and NORAD going to do? ADR and NORAD are also going to cause peripheral vasoconstriction. They will cause peripheral vasoconstriction. Now, when the peripheral vasoconstriction happens, blood is not going to flow to the peripheries, and the peripheries are going to become cold. So, you'll have cold peripheries. The hands and legs are going to become cold. Okay. Now, you know that when these arterioles vasoconstrict, what is going to happen to the peripheral vascular resistance? Common sense that if you have a constricted vessel, there is more resistance to the flow of blood to the peripheries, right? Which is why blood is not going into the peripheries, right? So, peripheral vasoconstriction will give rise to increased peripheral vascular resistance. PVR is peripheral vascular resistance. So, a simple rule of thumb which I want you to remember for all shocks which we discuss later on as well. Any shock with cold extremities, the peripheral vascular resistance increases. And any shock with warm extremities, the peripheral vascular resistance is going to decrease. So, just remember the simple rule of thumb. Okay. Now, why is the body causing peripheral vasoconstriction? Another common sense question. The body is causing peripheral vasoconstriction because it wants that the blood should go to the vital organs, the heart, the brain, and the vital organs, right? So it wants to shunt blood from the peripheries to the vital organs. And that is why this vasoconstriction is happening. This is going to shunt blood to vital organs. And because this shunts more blood to vital organs, the cardiac output and the systolic blood pressure are going to remain normal. Because more blood is returning to the heart, the cardiac output and the systolic blood pressure remain normal, which is why we are saying this is the compensated phase. That despite blood loss, the body has adjusted and there's been no loss in systolic blood pressure. Okay. So let's fill out the table now. We know that pulse rate is increasing. This is the earliest indicator of hypovolemia. Systolic blood pressure is normal. What happens to the diastolic blood pressure? You've read in physiology that if the peripheral vascular resistance increases, then the diastolic blood pressure will also increase, right? So, diastolic blood pressure increases. Now, understand one thing. This is our systolic blood pressure, it is remaining normal. This is my diastolic blood pressure. Systolic blood pressure minus diastolic blood pressure is pulse pressure. Systolic is here, diastolic is here. Systolic is not moving, but diastolic is increasing. So if diastolic increases, the difference between the two reduces. So the pulse pressure is going to become narrow. The pulse pressure becomes narrow. Okay. Respiratory rate is going to remain the same. Urine output is normal or slightly reduced. The mental status, patient is going to be thirsty and anxious. Patient is going to be thirsty and anxious. And the base deficit is going to be -2 to -6 milliequivalents per liter. So some amount of acidosis has started happening now, right? So -2 to -6 milliequivalents per liter is the base deficit. And these patients are going to require IV crystalloids. You know crystalloids, I've discussed in the chapter in nutrition and fluid about crystalloids, and we can use normal saline or Ringer lactate here in form of crystalloids to manage these patients. Now, class 3 shock is the decompensated phase of hypovolemic shock. This is the decompensated phase of hypovolemic shock. What do we mean by the decompensated phase? That now the body has lost so much of blood that now the systolic blood pressure cannot be maintained. So now systolic BP will start to fall. Okay, because body has lost so much of blood. So what is going to happen here? That there's going to be further tachycardia. Tachycardia increases, right? You have a rapid thready pulse. Systolic blood pressure now starts to fall. This is again a very, very important MCQ. In which class of hypovolemic shock does systolic blood pressure fall for the first time? Class 3 shock. Okay, so systolic BP falls for the first time in class 3 shock. Remember that, please. The diastolic blood pressure also falls. Why? Because there is loss of circulatory volume. So although there is vasoconstriction, so the peripheral vascular resistance is increasing. But now because blood is being lost, so much of blood is lost that now diastolic blood pressure will also fall. So the pulse pressure becomes even narrower because now both are falling. So the pulse pressure becomes even more narrow. Respiratory rate is going to increase. Patient will have tachypnea. Urine output now starts to fall dramatically. Okay. And this patient is now confused. Patient is now confused. And the base deficit is -6 to -10 milliequivalents per liter. -6 to -10 milliequivalents per liter. Now these patients cannot be managed alone with crystalloids. So they have to be given IV crystalloids plus colloids. And colloids, I showed you in that table in the chapter on fluids. You can give albumin, Hess starch, there can be dextran, various types of colloids can be there. But even blood products are colloids. So class 3 shock patient, you can give blood products as well, right? So we'll give crystalloids and colloids, and crystalloids to colloids are given in a 3:1 ratio. 3 parts of crystalloids to 1 part of colloid. Okay. So class 4 shock is also very easy to remember. The patient has lost so much of blood that everything is non-recordable, right? So you will have pulse rate is non-recordable, right? You'll have pulse rate non-recordable. You will have BP non-recordable. You can't record the pulse pressure. The respiratory rate increases even more. The patient has anuria. No urine production is there. This patient will be in a state of coma. And it will be more than minus 10 milliequivalents per liter. The base deficit is more than minus 10 milliequivalents per liter. Right? So these are the 4 classes of hypovolemic shock. And in this patient with class 4 hypovolemic shock, what do? We have to give these patients massive blood transfusion. We have to give these patients a massive blood transfusion. And I'm going to talk about massive blood transfusion in a few minutes time. Very important topic, a pet favorite for the AIIMS and the Central Institute exams. But class 4 shock patients require massive blood transfusion. Okay. So this table is very important for you to understand. I've tried to simplify it as much as I could for you. Let's solve one question here so that you understand what kind of practical questions are asked from this table. So let's look at this question now. You have a 70 kg man who's come to the emergency following a stab injury to the abdomen, right? His pulse rate is 110, so there is tachycardia, and BP is 90/60, means systolic is also falling and diastolic is also falling. And he appears confused. What percentage of blood volume has he lost? So very simple. How do we approach these questions? There is tachycardia here, right? So it cannot be class 1 shock. Has to be either class 2, class 3 or class 4, right? First thing. Second thing, systolic BP has started falling. It is 90 systolic. So systolic BP has started falling. So when does systolic BP fall for the first time? In class 3 shock. Why isn't this class 4 shock? Because you can still feel the pulse, you can still record the BP. It is not non-recordable, right? So this would be class 3 shock. And class 3 shock, again remember the scoring of a tennis game. Class 1 was 0 to 15, class 2 was 15 to 30, class 3 was 30 to 40%. So 30 to 40% blood loss has been there in this person, and the patient is suffering from class 3 hypovolemic shock. So these are the kind of practical questions which can be asked from the table which we've just discussed. So we've discussed the classes of hypovolemic shock and I've broadly outlined the treatment for you. Now it is also very important that such patients should be monitored at a regular basis. So how do we monitor a patient with hypovolemic shock? That's a very important concept for you to understand. Now there are 2 common questions, and these 2 questions have been asked at least 20 times in your exam. The first question is, which is the best indicator to determine amount of fluid required? Best indicator to determine amount of fluid required in shock, right? And the second question is, which is the best clinical indicator? Which is the best clinical indicator of fluid resuscitation? Of fluid resuscitation in shock. Okay. Now, what is the literal meaning of these two definitions? The first question is asking that when a patient comes to me in the emergency, how do I determine how much fluid to give to that patient, right, of shock? How much fluid is to be given, which is that indicator? And the second question is that once I have given fluid to this patient, how do I know whether that was adequate fluid or inadequate fluid? So I hope you've understood the two questions. Now the first question is how to initially determine how much fluid to give. There the answer is pulmonary capillary wedge pressure is a better answer than CVP. This is pulmonary capillary wedge pressure, and CVP, all of you know, is central venous pressure. So for all practical purposes, it is the central venous pressure which is what we use to determine how much fluid to give. But theoretically speaking, pulmonary capillary wedge pressure is a better answer than CVP because it gives you an accurate indicator of the left-sided heart pressures, whereas CVP is giving you an indicator of the right-sided heart pressures. Okay, so theoretically pulmonary capillary wedge pressure is a better answer. Otherwise, for practical purposes, it is CVP. And pulmonary capillary wedge pressure, you know that we use a Swan-Ganz catheter and then we measure the pulmonary capillary wedge pressure. Okay, so this question has been asked many times. You should remember this. Now, once you have given fluid, how do we know whether that fluid has been adequate or inadequate? So that is determined by the urine output. That is determined by the urine output. Very, very important question. These two questions have been asked at least 20 times in the exam. So you should read the question carefully and then answer after assessing what is the examiner trying to ask you. Okay. Now the urine output for adults, in a patient with shock, the urine output for adults should be maintained more than 0.5 ml per kg per hour. Whereas for children, our aim should be that it should be more than 1 ml per kg per hour. Now, in addition to this, there are certain new endpoints of fluid resuscitation as well. These have been listed in Bailey and they are very important for the exam, asked a lot of times in the last couple of years. So what are the new endpoints of resuscitation? The new endpoints of resuscitation for systemic perfusion. So for systemic perfusion, the new endpoint of resuscitation which you need to remember for your exam is MVOS. This is mixed venous oxygen saturation. I'll talk about this in detail in 2 minutes. Mixed venous oxygen saturation. The second one is base deficit, which I've already told you is because there is acidosis. And the third one is serum lactate. So these are the three for systemic perfusion. These are the new endpoints. And if you have to choose the single best endpoint of resuscitation, it is MVOS, right? So for any future exam, if they ask you which is the best endpoint of fluid resuscitation, and you have urine output also mentioned there, you have MVOS also mentioned there, you will mark MVOS, right? That is the single best endpoint of resuscitation. If they ask clinical endpoint, you will mark urine output. Okay, so please no confusion there. For muscle perfusion and for brain perfusion, it is the same. For muscle perfusion and brain perfusion, the endpoints of resuscitation are NIRS, that is the near infrared spectroscopy. NIRS is near infrared spectroscopy, and tissue oxygen electrode. Tissue oxygen electrode. So these are the two endpoints of resuscitation for muscle and brain perfusion. For gut perfusion, There are three of them: sublingual capnometry, gut mucosal pH, and laser Doppler flowmetry. Okay, so you have sublingual capnometry, gut mucosal pH, and laser Doppler flowmetry. You have to remember these endpoints. This is a table directly from Bailey, but please remember that MVOS is the single best endpoint of resuscitation. One more thing which I want to tell you here, and I've covered this in the stomach module as well, that the gastric mucosa is the most sensitive mucosa. It is the most sensitive mucosa in GIT to hypovolemic insult. So whenever there is a hypovolemic insult in the body, it is the gastric mucosa which is the most sensitive, right? What is the practical importance of this? Because the gastric mucosa is most sensitive, that is why you can get stress ulcers. Whenever there is hypovolemic shock, patient can develop stress ulcers, and that can lead to bleeding. So these two types of stress ulcers, which I've discussed in both upper GI hemorrhage and the burns module, are Cushing and curling ulcers which develop in a stressful condition. So this is how we monitor a patient with hypovolemic shock. Before I move further and tell you more indices, let me tell you about MVOS. What exactly is MVOS? So this stands for mixed venous oxygen saturation. Right, so this is the amount of oxygen which is returning back to the heart after being utilized in the body. That is MVOS. So let me simplify this for you further. So supposing 100 molecules of oxygen are pushed from the heart into the body, right? Now the body is going to utilize this oxygen. So supposing the body utilizes 50 molecules of oxygen and 50 molecules are returning back to the heart. So that is the MVOS. The percentage of oxygen which is returning back to the heart is mixed venous oxygen saturation, right? So accurate measure of MVOS can be done by drawing blood from a catheter in the right atrium. That is going to give you the accurate measurement. Why not the SVC? If blood is drawn from the SVC, if blood is drawn from the superior vena cava, then you can get an inaccurate measurement. You can get an inaccurate measurement. Why? Because there is more oxygen extraction, because more oxygen extraction occurs in the lower limbs. So you will get a false value here, falsely high value, because more extraction is happening from the lower part of the body or the lower limbs. So for accurate measurement, it should be from the right atrium. Now the normal value of MVOS is between 50 to 70%. That is the normal value of MVOS. Less than 50% MVOS, where are we going to get less than 50% MVOS? So it's a common sense question. One is if the heart is pushing less oxygen, right? Or the second is if the body is utilizing more oxygen. Those are the two situations when you are going to have a low MVOS, right? So low MVOS will be seen in patients with cardiogenic shock because the heart is unable to pump out oxygen, and you will have it in hypovolemic shock. Why in hypovolemic shock? Because I told you there is peripheral vasoconstriction, right? And there is stasis of blood which is happening. And because the circulating blood is less, there is less oxygen which is being sent. So because less oxygen and stasis is there, the body extracts more oxygen. The tissue is going to extract more oxygen and less oxygen is going to return. So that also leads to a low MVOS. So these are the two types of shocks where you can get low MVOS. Now, where can we get high MVOS? Will be seen in patients with septic shock. Why septic shock? Septic shock, we are going to discuss later. The warm phase of septic shock is a hyperdynamic phase, right? The warm phase is a hyperdynamic phase. So because there is a hyperdynamic phase, there is quick circulation. Quick circulation is there. And this leads to less extraction of oxygen. Also, there is impaired tissue oxygen extraction in septic shock. Impaired tissue oxygen extraction. So these two reasons lead to a high MVOS in patients with septic shock. So I've told you what is MVOS. I've told you the causes of low and high MVOS. This you should remember for the exam. So even in distributive shock, right? Distributive shock like anaphylactic shock and neurogenic shock also, you can get a high MVOS. Because there also the same thing is happening, that you have stasis of blood, so more oxygen is being extracted in these patients. Okay. So this was regarding MVOS. Now there are certain indices which I want you to remember. They've been asked in the AIIMS exam. These are also used to monitor shock. One is shock index. So the first index which I want you to know is the shock index. Shock index is heart rate by systolic blood pressure. Okay. The other one is modified shock index. The other one is modified shock index. Modified shock index is heart rate divided by mean arterial pressure. MAP is mean arterial pressure. And the third one is ROPE. ROPE stands for rate over pressure difference. Stands for rate over pressure difference. That is ROPE. So rate means heart rate and pressure difference. What is pressure difference? Systolic minus diastolic is pulse pressure. So heart rate by pulse pressure is ROPE. Now, out of these three, modified shock index is the most sensitive indicator. Modified shock index is the most sensitive indicator. This point has also been asked in the exam. Okay. Another thing which I want you to remember is that a shock index, if you have a shock index ratio of more than 0.9, then there is higher mortality. This is very important. This is from a large scale study which was done, and this found out that if shock index is more than 0.9, higher mortality. Okay. And if the ROPE value is less than 3, patient remains stable. But if ROPE, that is rate over pressure difference, is more than 3, then it is indicative that the patient might develop decompensated hemorrhagic shock. So if you can, for the Central Institute exams, please remember these two values: shock index of more than 0.9 and ROPE of more than 0.3. Again, higher mortality, poor outcome. So I've told you various things how to monitor hypovolemic shock. Now I have to discuss a very important point, that is massive blood transfusion. Massive blood transfusion, you need to remember for the exam, because almost each year there is a question which is being asked from this topic. First, what is the definition of massive blood transfusion? The definition of massive blood transfusion is when we replace entire circulating volume in 24 hours. That is number one. Or if more than 10 units of blood are given in 24 hours, that is number two. And number three is if more than 4 units of PRBC or blood products are given in 1 hour. So these are three definitions which you need to remember for massive blood transfusions. The definition itself has been asked many times in the exam. Now you know when such large quantities of blood is required, there has to be a protocol. So there is a massive blood transfusion protocol which is initiated whenever we anticipate that a patient would require such large quantities. Okay. Before I joined my post-graduation, I had done an externship at Cornell and Harvard. And at Cornell, I was at a level 1 trauma center in Bronx. Now, Bronx is one of the areas in New York, but it is notorious for crime, right? And that level 1 trauma center was in the middle of that high violence zone. And every night I was on call, you could hear at least 3 or 4 gunshots happening outside. So one such patient landed up to the ER with 4 gunshot wounds to the abdomen, right? And the patient had non-recordable vital signs when the patient came in. Patient was resuscitated and we activated the massive blood transfusion protocol. Okay. In 24 hours, this patient was given 14 vacs of blood products. Okay. So classified as massive blood transfusion. Now, when you are giving such large quantities of massive blood products, there are bound to be certain complications as well. So what are the complications of massive blood transfusion? The complications of massive blood transfusion, you know that blood when we get from the blood bank, it is cold, right? And normally if I have to transfuse just 1 unit of blood, we will take our own sweet time for the blood to come to room temperature and then we start transfusing. I'm sure as interns, all of you must have done that. But in patients where we are in a hurry, we have to transfuse 10 units in 24 hours or 4 units in 1 hour, there we don't get enough time to warm up this blood, right? So in these patients, when we are giving blood so rapidly, these patients can become hypothermic. There can be hypothermia. Okay. Now you also know that when we are giving blood, when you're storing blood, it has an anticoagulant with it. And these days the anticoagulant used is citrate. So citrate is the anticoagulant which we are using these days. And because citrate is going to chelate calcium and magnesium, these patients can develop hypocalcemia and hypomagnesemia. They can develop hypocalcemia and hypomagnesemia. Now, normally there is 80 ml of citrate which is there. Okay. This 80 ml of citrate is normally metabolized by a normal person like us can metabolize it in 10 minutes. But patients who are in shock cannot metabolize the citrate effectively. So massive blood transfusion can also give rise to citrate toxicity later on. This can give rise to citrate toxicity later on and it can worsen the metabolic profile of the patient. What happens to potassium? So potassium, you can either have hyperkalemia or there can be hypokalemia. Why? Hyperkalemia, because you know that stored RBCs can lyse. Stored RBCs can lyse, and when stored RBCs lyse, potassium is released. Also later on, when there is acidosis, that can also increase the potassium. Hypokalemia, why? Because RBCs after transfusion can actively, because the RBCs after transfusion can actively take in potassium, and that can give rise to hypokalemia as well. There can also be metabolic alkalosis initially. Why will there be metabolic alkalosis? This is due to citrate toxicity. Citrate metabolism is going to give rise to metabolic alkalosis, but later on this is then replaced by metabolic acidosis. So both alkalosis and acidosis, later on there is acidosis. Of course, you can have the blood transfusion reactions which are there. Because we are giving so much of blood, the blood transfusion reactions, which are the febrile reactions, you can have febrile reactions which are the most common, and rarely you can also have an anaphylactic reaction if there is a mismatched blood transfusion. Other problems which can happen in these patients, there are two terms which I want you to know. These two terms have also been asked in the exam in the last 2 years. TACO and TRALI. What is TACO? TACO is transfusion associated. TACO is transfusion associated cardiac overload. Transfusion associated cardiac overload is TACO. And TRALI is transfusion related acute lung injury. Transfusion related acute lung injury is TRALI. Now, as interns, I'm sure you people must have transfused blood to patients, and sometimes you must have transfused 2 or 3 units as well. Sometimes what happens when you transfuse blood, there can be a volume overload. And how will that volume overload manifest in the patient? That volume overload will manifest as puffiness of the face, and edema, and these can be signs of cardiac overload. And this will develop as you're transfusing blood. Within some time of that only you will notice these changes. And I'm sure all of you must have seen that when you notice these changes, your senior comes and your senior says, well, this is due to fluid overload. What do we need to do here? We need to give this patient Lasix, right? We need to give this patient diuretics or Lasix, and that is going to take care of this problem. So diuretics are to be given if you have TACO. TRALI, on the other hand, is transfusion related acute lung injury. Now TRALI usually develops within 6 hours of transfusion. Within 6 hours of transfusion, you are going to have TRALI, and it is hypothesized that this is due to anti-HLA antibodies, and this is going to give rise to a picture of ARDS, acute respiratory distress syndrome, right? You've read acute respiratory distress syndrome in medicine in great detail. So you'll have bilateral chest infiltrates, there will be tachypnea, saturation would be low. But the good thing is that if TRALI is detected early and treated adequately, then it has a good recovery rate as well. Okay. So these two terms you need to remember, TACO and TRALI. One final point regarding massive blood transfusion, the most common cause of death in massive blood transfusion, this question has been asked multiple times, is coagulopathy. It is not TRALI, it is coagulopathy. So why is coagulopathy occurring in these patients? Coagulopathy is occurring because of hypothermia, because of hypothermia. You remember the chapter of trauma where I've spoken about abdominal trauma, I'd spoken about damage control surgery. There I've told you the terrible triad of trauma. The terrible triad of trauma is hypothermia, acidosis, and coagulopathy. So all three are related. Right? The other cause is, as I mentioned, there can be acidosis, and the most important thing is dilutional coagulopathy is there. There is dilutional coagulopathy. What do we mean by this? We know that the blood which we are transfusing is stored blood is poor in, stored blood is not rich in platelets, and it has decreased clotting factors. It has decreased clotting factors. So there can be dilutional coagulopathy here. Now, how to deal with this problem of coagulopathy in massive blood transfusion? So to deal with this problem, the massive blood transfusion protocol, and this has also been asked 2 or 3 times, is that the ratio of PRBC to FFP to platelets in massive blood transfusion should be 1:1:1. So PRBC is packed RBCs, FFP is fresh frozen plasma, and you have platelets. So the ratio should be 1:1:1 when we are doing massive blood transfusion in order to avoid coagulopathy. Okay. Now these blood products, their storage, how do we transfuse them, has been covered in great detail in pathology by Dr. Illa in the blood banking module, right? I want you to listen to that module along with the shock module, because those values are asked in the exam. The reason why I don't want to tell you the values here, because we compared and the values in Bailey and the values in Robbins are different. And blood banking, there is a standard book for blood banking. So Dr. Illa has covered values from that standard book. So I want you to remember those values rather than the ones which are mentioned in Bailey. So this is how we prevent coagulopathy. Now another thing which I want you to know here, there are 2 scores which are for massive blood transfusion. These are scores which help in taking decisions regarding massive blood transfusion, especially in trauma patients. You have the ABC score. It has 3 parameters: penetrating trauma mechanism, systolic BP less than 90, heart rate more than 120, and positive fast. And you have the TASH score. You need to remember the full form of TASH score. It is trauma associated severe hemorrhage score, and it has 7 parameters in it. These 2 scores have not been asked in the exam as of now, but I just want you to remember the names and the full form of TASH. You also need to remember about blood substitutes, right? Sometimes we don't get blood. Supposing you know that we are in a very tricky situation with China right now, and it is in a place like Ladakh, and you have, if there is going to be a fight, it's going to be on high altitudes where you don't have a blood bank, you don't have stored blood there as well. So in places like those, you need to have blood substitutes also to maintain the patient's life till you can shift the patient to the hospital. Okay. So these blood substitutes, you have first generation substitutes like perfluorocarbons, second generation are stroma-free hemoglobin, and the latest generation, the next generation which is being evaluated these days is polyethylene glycol hemoglobin. Hemospan, a lot of trials have been done in Hemospan. This is pegged conjugated human hemoglobin. And you have pyridoxylated hemoglobin polyoxyethylene conjugate, PHP, this has also been evaluated. So I just want you to remember the names. Again, this has not been asked in the exam till now. I've also told you about this anti-shock garment when I was talking about pneumatic anti-DVT stockings. I told you about this anti-shock garment as well. This anti-shock garment, you have numbering from 1 to 6, and this is used in patients with hypovolemic shock. So where do we use it? Supposing you have a lady who has delivered in a primary health center and she starts having postpartum hemorrhage. Now the primary health center is not well equipped to manage this postpartum hemorrhage, and you need to shift the patient to the hospital, but the hospital is 1 hour away. So of course you're going to give fluids to the patient, but you'll also tie this garment. And this garment, there is sequential compression, maximum compression here and least compression here as we go up. So what this does is that this squeezes out blood from the limbs and sends it to the heart so that the blood pressure can be maintained for some time till the patient is shifted to the hospital. Okay. So this was regarding massive blood transfusion. Another thing which I want you to know, there are some key definitions which I want you to remember in hypovolemic shock. One is occult hypoperfusion. This is the new term which is there in Bailey, and you need to remember this. So occult hypoperfusion means that the patient is going to have normal cardiovascular parameters. Patient is going to have normal cardiovascular parameters. That means pulse rate, BP. Patient is going to have normal urine output. Normal urine output, but there is going to be low MVOS and acidosis, right? So this is the preclinical state of hypotension. This is occult hypotension where the parameters are normal, your cardiovascular and urine output, but there is low MVOS and there is acidosis in this patient. Now what is the importance of occult hypoperfusion? That if occult hypoperfusion, if it lasts for more than 12 hours, then there is a poor outcome. So we need to identify occult hypoperfusion early and we need to manage it on time. What is dynamic fluid response in shock? So any patient with shock, we've discussed that we have to give fluids to these patients. And whenever we get a patient with shock, we give a bolus of fluid. We give a bolus of fluid, which is 250 to 500 cc bolus we give as soon as we get this patient. And a normal response after giving this is that the CVP increases by 2 to 5 centimeters of water. CVP rises by 2 to 5 centimeters of water, and it gradually normalizes. It gradually normalizes in 20 minutes or so. So this is normal response. Now there can be 3 types of responses in a patient with shock. You can have responders. Once you give this fluid, you can have responders. Responders, I've just told you that they will be a CVP rise and it will then normalize, like I've just told you. Then you can have non-responders. Non-responders, when there is no change. And you can have transient responders. And you can have transient responders. Transient responders will show a rise in CVP, will show rise in CVP, but CVP again returns to pre-treatment value. That means again low CVP in 10 to 15 minutes. So initially they show a spike, they show an increase, but then it returns to the pre-treatment value in 10 to 15 minutes. So these are the three kind of responses which we can get when we give fluids to a patient of shock. How does this help me as a clinician? Non-responder means that the patient is losing so much of blood that the rate at which I am giving is not able to match with the rate of loss. So we need to evaluate what is the cause of loss and we need to treat that. Transient responder means that there is ongoing losses happening. So again, these patients we need to monitor carefully and we need to identify the cause and treat that as well. Okay. So these are the three types of responses which we can get in a patient with shock. Another important update in the 27th edition of Bailey is that the perioperative blood transfusion guidelines have been changed. Perioperative transfusion means after surgery, if a patient is to be given blood or not given blood, those are now determined by these guidelines, and you need to remember this is very important, that if the hemoglobin is less than 6, then there is going to be benefit from transfusion. If the hemoglobin is 6 to 8, only give blood. We only give blood if ongoing losses are there. If ongoing losses are present, then only we give blood. And more than 8, there is no indication of giving blood transfusion if the hemoglobin is more than 8. So please remember these parameters. One final thing which I want you to know, this was asked in the AIIMS exam a couple of years back. When we are giving blood, there is a special filter which we can use here. This is known as a leukoreduction filter. This is a leukoreduction filter. Again, the details have been covered in the blood banking module by Dr. Ella. So leukoreduction filter, it reduces the incidence of febrile reactions. It reduces the incidence of febrile reactions. So this takes care of hypovolemic shock. It is a very, very important topic.